So for anatomy, let's start by talking about the different regions of the colon, starting at the very bottom left of your screen here. In your right lower quadrant, you have your cecum. Attached to that is your appendix. We also have our ascending colon, transverse colon, descending colon, and finally the sigmoid colon. So starting with the cecum, I'll just tell a few things about the cecum that you should know. It's the first region. It's connected directly to two structures. It's connected to the appendix through a blind pouch, and it's also connected to the small intestine through this thing called the ileocecal valve. They do like you to know some things with the ileocecal valve, so I'll talk about those here. Two conditions you should be aware of are intussusception and gallstone ileus. The reason why intussusception happens here, as I'll talk about, we talk about this in the small intestine lecture, what intussusception is. What it is where you have, if the bowel is flowing in this direction, you can have part of your bowel, the proximal bowel, actually move into the segment distal to it. And the reason why this is common at the ileocecal valve is that the valve itself can act as a lead point. It basically acts as a region where some of the bowel can attach to, and that allows the bowel that's proximal to it to start shifting through, and that would look something like this. Another thing I want you to keep in mind when you think about the ileocecal valve is in the condition gallstone ileus. I talk about this more in the hepatobiliary lecture coming up, but I just wanted to point out here on one of our slides from that lecture that usually in gallstone ileus, the gallstone makes it pretty far down the intestinal tract, but it ends up getting stuck at the ileocecal junction because that's the smallest point in the GI tract. And here again, this is also from that lecture. If you have a gallbladder that's eroded through the gallbladder wall, excuse me, if you have a gallstone that's eroded through the gallbladder wall and into your small intestine, it can travel all the way down to the ileocecal valve, but it'll get stuck there because it's often the smallest point in our intestine. Moving on to the appendix, all I want to say about the appendix right now is that it's a blind pouch that extends off the cecum. It used to be thought that it was a useless vestigial structure, but lately there's some evidence that suggests that the appendix has some role in immune function and its microbiome might be beneficial for the host. And when you think about the appendix, you're going to probably think about the classic appendicitis and some of the complications that arise from appendicitis, such as an appendiceal abscess. And we'll talk about appendicitis later on in this lecture. In the ascending colon, also known as the right-sided of the right colon, this is useful for absorbing water and salts. I want you to remember that this region of the colon is retroperitoneal. And if I go back to our, this is the slide from our GI intro when I talk about intra versus retroperitoneal. I just want to point out that in the colon, the ascending and descending colon are the two retroperitoneal structures. It's got a very large diameter. And if you think about it, it's more watery. As we get to the more distal regions of the colon, you're going to have a less watery stool composition. It'll be more well formed like actual stool. And this plays a role if you have a large diameter and a watery composition. It's really hard to have an obstruction. So you're not really going to get too much of an obstruction here if you have some sort of tumor on the right side of your colon. This is a slide that I'll show you later when we talk about colon cancer. And all I wanted to point out here is that if you notice our right-sided tumors, which is what we're talking about here, their main problem is bleeding. They don't really have a problem with obstruction because, like I said, it's more of a watery composition and the diameter is big enough to where it's not a problem. The transverse colon has a few things that you should recognize. It's the longest portion of the colon. That's not going to be tested. But what is tested frequently is the differentiating landmarks between your foregut, midgut, and hindgut. And we've talked about this before, but I just want to remind you that the midgut ends at the distal portion of the transverse colon, and the hindgut starts in that region. And what that means is that your first 2/3, your more proximal 2/3 of your transverse colon is going to have a different blood supply and a different nerve supply than the distal 1/3 of your transverse colon, because embryologically they arose from different regions. So here you go. In the blood supply, we have our SMA, our superior mesenteric artery for our proximal 2/3, and our inferior mesenteric artery for the distal 1/3. And for our parasympathetics, we have our vagus nerve for the proximal 2/3, and you have pelvic splanchnic nerves that supply the distal 1/3. Two other landmarks I want you to be aware of as they pertain to the transverse colon. First, we have our hepatic flexure, and this is the region that connects the ascending colon and the transverse colon, and I've circled it to the image on our right. A more important landmark that you'll get tested on is the splenic flexure, and this is the connection between the transverse and descending colon on the right there. And why this is important is because the splenic flexure is actually what's considered a watershed area. This is the first time we're going to talk about watershed areas. And what I want you to know about watershed areas is that those are regions with very poor perfusion pressures. And because they have such poor perfusion pressures, they can be susceptible to ischemia. Usually this happens during periods of systemic hypotension. So if somebody's in shock, these watershed areas are often the regions that are most likely to be damaged by these incidents. And we have two watershed areas in our colon that I want you to know about. The first is what we just talked about, the splenic flexure, highlighted to the right. And the second region we should be aware of is the rectosigmoid junction, which is located right here. Moving on to the descending colon, also known as the left colon, again, this is a retroperitoneal structure. And going back to this slide, you can see the descending colon is included. And this is more responsible for storage of feces. It's less responsible for absorption. At this point, most of the absorption has already been undertaken place. And keep in mind, because there's a decreased diameter in this region and the stool has more of a solid composition, you're at a higher risk of obstruction if you do have a tumor growing on your left side. So again, going back to the slide that we'll talk about later, you can see that left-sided tumors are known to cause obstructive symptoms. And the last section of the colon that you need to know is the sigmoid colon. It's the final segment of the colon before it reaches the rectum. It's actually named because of the sigma shape that it takes. And we'll talk about some of these conditions later on in this lecture, but I want you to remember that conditions like diverticulosis and sigmoid volvulus are very common in this region. Moving on to blood supply, most of the blood supply to the colon is fairly straightforward. Just remember that because it has midgut and hindgut origins embryologically, that you're going to get blood supply from both the SMA and IMA, depending on where you are in your colon. So starting with the cecum and appendix, because they're part of the midgut, you should expect them to receive blood from the superior mesenteric artery. And so it's going to come from superior mesenteric straight to the ileocolic artery, which is the yellow arteries here in this picture. For the ascending colon, that's going to go from this SMA to the right colic artery. And then for the proximal 2/3 of the transverse colon, that's going to go straight from the SMA to the middle colic artery. Now moving on to the regions of the colon that are supplied by the hindgut, or the IMA, the transverse colon will be supplied by the inferior mesenteric artery, which will branch off here to the left colic artery and eventually attach to the marginal artery here to supply this distal region of the transverse colon. The descending colon has a little easier route. It just goes straight from the IMA to the left colic artery. And the sigmoid colon also has a pretty straightforward route going from the IMA to the sigmoid arteries. Again, here's the picture of the watershed regions we just talked about. Well, actually, first, before I talk about watershed, I'm going to talk about this marginal artery anastomosis, excuse me. So this is an important connection. We've talked a little bit about anastomoses in the stomach lecture. So in this case, we have an anastomosis, as you can see up here. And what's nice about this is it actually connects a region of our superior mesenteric artery to our inferior mesenteric artery in this circle right here. And what's good about this is that occasionally this could protect you if blood flow is, if a vessel is obstructed for whatever reason. So for example, if this region here, let's say there's some sort of clot in this region, normally distal to that clot would be at risk of hypoperfusion. But in the case, because of this anastomosis, we can actually have blood that travels all the way around and supplies this region. And I'm just going to take just a second. I'm going to delete that. Something that confused me, I remember this during medical school when I was studying for step 1 myself. I was confused by why this area would be safe, even though we described it as a watershed region. The difference between those two statements, if this is obstructed right here, let's say, and you still have very good perfusion, like your blood pressure is still good, then it's no problem for the blood to get all the way over here. And that's why the anastomosis works. It's only in conditions where you have systemic hypoperfusion, where you don't have really good blood supply, blood pressure to get the blood pumped all the way out here. That's when you run into those problems. I just wanted to make the distinction there between a watershed and an anastomosis, why the anastomosis works in this spot. And so here is the watershed region I wanted to talk about. And we've already kind of gone over it, but the only thing I wanted to point out in this slide is kind of how it works. I know 2 arteries are supplying this region, so it seems like you might get better supply. The problem with that theory is that the pressure way out here is far, far less than the pressure you get here. So what do I mean by that? Let's say if you measure the blood pressure at these spots, right here, this is coming straight off of the aorta, so and the IMA. So you're going to get very strong pressures coming in here. And as we go distal, you can see how the pressures start to lighten up. And now that this kind of makes more sense, that even though you have 2 arteries supplying it, you can see that the total perfusion of this area is much less than, let's say, this region here, even though this only has supply from the inferior mesenteric artery or left colic artery. Just a few features that you should know about the large colon. They're pretty low yield, but it's good to know what a haustra is. The haustra are these small pouches that you see throughout the colon. You can see them all right here. Here's a haustra, boom, boom, boom. And they give them this segmented appearance. And the Taenia coli are these longitudinal muscles that span the colon. You can see only one here. There's actually 3 of them. And what you should know is that all 3 Taenia coli converge at the root of the appendix. Again, very low yield. I don't think that's been tested. That gets pimped on some surgery rotations, so that's sometimes good to know. Otherwise, it's kind of useless. Physiology, the colon physiology is extremely straightforward. It can absorb materials, it absorbs water, electrolytes, and vitamins, and it can move food down the GI tract for excretion. And there's some microbiota function. We need some healthy bacteria in our colon to help digest certain substances and to create certain things like vitamin K. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.